Uh, Flecainide is a Vaughan-Williams class 1C antiarrhythmic. It slows conduction of the action potential by acting as a potent sodium chloride channel blocker. This may be reflected by widening of the Cures complex and prolongation of the PR interval. The cardiac arrhythmia suppression trial investigated the use of agents to treat asymptomatic or mildly symptomatic premature ventricular complex post MI. The hypothesis was that this would decrease the death from ventricular arrhythmias. Flecainide was actually shown to increase mortality post MI and is therefore contraindicated in this situation. The indications of flecainide are atrial fibrillation, supraventricular tachycardia associated with accessory pathway like Parkinson-White syndrome, and adverse effect is negatively inotropic, bradycardia, proarrhythmic, oral paresthesia, visual disturbance. Adrenoreceptor antagonist. Alpha antagonists are alpha 1 doxazosin, alpha 1 tamsulosin, and acts mainly as an urogenital tract, on urogenital tract. Then alpha A2, alpha 2 yohimbine, non-selective would be phenoxybenzamin, previously used in peripheral arterial disease. Beta antagonist would be atenolol, beta 1, non-selective is propranolol. Carvedilol and labetalol are mixed alpha and beta antagonists. Statins inhibit the action of HMG CoA reductase, the rate-limiting enzyme in hepatic cholesterol synthesis. Statins reduces cholesterol synthesis. The adverse effects of statins are myopathy, including myalgia, myositis, rhabdomyolysis, and asymptomatic raised creatine kinase. Raised factors for myopathy include advanced age, low BMI, presence of multisystem disease such as diabetes mellitus. Myopathy is more common in lipophilic statins like atorvastatin and simvastatin, relatively hydrophilic statin, which are rosuvastatin, pravastatin, pravastatin. So rosuva is a hydrophilic. This one is lipophilic. Atorva. Okay, liver impairment. NICE recommends checking LFT at baseline, 3 months and 12 months. Treatment should be discontinued if serum transaminase concentration rise to and persists at 3 times the upper limit of the reference range. 3 times the upper limit. If the upper limit is 40, it should be 120. If less than 3 times the upper limit, then it should not be routinely excluded from the statin therapy. Okay, P450 inhibitors increases CK, myopathy. Who should receive a statin? It's a question. NICE 2016 says secondary prevention, established cardiovascular disease like stroke, TIA, ischemic heart disease, or peripheral arterial disease. Use atorvastatin 80 mg for secondary prevention. Use a lower dose if potential drug interaction and increased risk of adverse effects. Patient preference. So the primary prevention, lifestyle modification is first line, and if this fails, estimate 10-year cardiovascular risk using Q-risk 2. Atorvastatin 20 for primary prevention if 10-year CVT risk is more than 10%. Diabetes. Consider statin for all type 1 diabetes. Do not use Q-risk for type 1 diabetes. Offer statin for type 1 if age is more than 40, DM is more than 20 years old, established nephropathy, and other CVT risk. Offer atorvastatin 20 mg for type 2 diabetes. CKD offer atorvastatin 20 for the primary or secondary prevention. Age more than 85, consider atorva 20, and familial hypercholesterolemia, do not use Q-risk. Simvastatin should be taken at night, as this is when the majority of cholesterol synthesis takes place. Simvastatin has a shorter half-life than other statins. And target cholesterol, NICE does not recommend a fixed target for primary or secondary prevention, but recommends aiming for more than 40% reduction in non-HLD cholesterol. If target is not achieved, then discuss and optimize adherence, the timing of dose, and lifestyle measures. Consider increasing dose if started on less than atorvastatin 80 mg and the person is judged to be at higher risk. Side effects of drugs used in hyperlipidemia: statins, HMG, CoA reductase inhibitor, myositis and derangionality, ezetimibe, headache, nicotinic acid, flushing, myositis, impaired glucose tolerance, fibrates, myositis, pruritus, cholestasis, and so fibrates would be myositis, pruritus, cholestasis, and anion exchange resistance, GI side effect. Cholestyramine is reserved for true statin intolerance. Fibrates have been associated with myositis, especially when combined with statin. So, combining with the statin may result in myositis. Nicotinic acid increases HDL levels. Okay. The next one is a very important medicine, furosemide. It's a loop diuretic that acts by inhibiting chloride absorption in the ascending loop of Henle. The name of last 6 derived from the last 6 hours, referring to its duration of action. Last 6 hours. Okay. Maximum dose of furosemide as per BNF is 1.5 gram per day. It's frequently used underused in fluid overload. Patient with fluid overload due to heart failure usually require at least 50% extra of the usual dose. So that's what we do. Use it for fluid overload. We give Lasix. There are lots of side effects as well, like hyponatremia, hypokalemia, hypocalcemia, something ignored, hypochloremic alkalosis, Ototoxicity can also occur, renal impairment from dehydration and direct toxic effects. So this also takes away all the fluid, so there is dehydration. And then hyperglycemia, less common than thiazide, gout. Bumetanide is another loop diuretic that has similar characteristic to furosemide. 1 mg of bumetanide is equals to 40 mg of furosemide. The main difference is in their bioavailability and potency. 60% of furosemide is absorbed in the intestine, and there are substantial inter and intra-individual difference in bioavailability. About 80% of bumetanide is absorbed, and its absorption does not change when it is taken with food. It is said to be a more predictable diuretic, meaning that the predictable absorption is reflected in the more predictable effect. Very important topic. Bendroflumethiazide is another thiazide diuretic which works by inhibiting sodium absorption at the beginning of the DCT. So for Lasix, the root was in the defect in the chloride channel, inhibiting chloride absorption in the ascending loop of Henle, and next after ascending loop of Henle comes DCT. At the beginning of the DCT, there is this is where bendroflumethiazide works, inhibiting sodium absorption at the beginning of the DCT. Potassium is lost as a result of more sodium reaching their collecting ducts. Bendroflumethiazide has a role in the treatment of mild heart failure, although long diuretics are better for reducing overload. The main use of bendroflumethiazide currently is in hypertension. Part of the effect is due to vasodilation. So remember that bendroflumethiazide mechanism of hyperkalemia is increased sodium reaching the collecting ducts, activation of the RAS. So common adverse effect would be dehydration, postural hypotension, hyponatremia, hypokalemia. So both goes down. Also happens in Lasix. Both goes down. Right? See, hyponatremia, hypokalemia. So that also happens in bendroflumethiazide. Hypercalcemia, gout, impaired glucose tolerance, more in thiazide. Hyperglycemia, impotence can also occur. Rare adverse effect will be thrombocytopenia, agranulocytosis, photosensitivity, rash, very important. Pancreatitis as well. Another very important medicine we use for heart failure is spironolactone. It's an aldosterone antagonist which acts in the distal convoluted tubule. So both bendroflumethiazide and spironolactone both act in the distal convoluted tubule. So indication is ascites. Patient with cirrhosis develop a secondary hyperaldosteronism. Relatively large doses such as 100 or 200 milligrams are used due to secondary hyperaldosteronism. Heart failure, nephrotic syndrome, Cone syndrome. And adverse effects would be hyperkalemia and gynecomastia. rail study, New York Heart Association classification 3 plus 4. Patient already taking ACE inhibitor, you can use the spironolactone. Low dose spironolactone decrease all cause mortality. That's great. Next is adenosine. It's the effect of adenosine. Okay, the effects of adenosine are enhanced by dipyridamole, antiplatelet agent, and blocked by theophylline. It should be avoided in asthmatics due to possible bronchospasm. So don't use adenosine in asthmatic patients. Mechanism of action is causes transient heart block in the AV node. And agents agonists of the A1 receptor, which inhibits adenylyl cyclase, thus reducing CAMP and causing hyperpolarization by increasing outward porous influx. Adenosine has a very short half-life of about 8 to 10 seconds. Adverse effects of adenosine is chest pain, bronchospasm, can enhance conduction down exhale path, resulting in increased ventricular rate. So don't use it in asthmatics, and it's sometimes used as well. Dipyridamole enhances effect, aminophylline decreases effect. So you have to remember these two. Calcium channel blockers. These are all the cardiac drugs which we majorly use. The calcium channel blocker